First of all, I would like to thank the organizing committee for inviting us this year for the second time. Previous session, we had double trouble. Now, today we are going to present about this plasmacytic dilemma. Okay, our main theme for today is plasmacytic dilemma. Okay, as you can see in my screen now, three pictures showing plasma cell with aura-like bodies. Can you appreciate these three pictures?
You mean our rods inside plasma cells?
Yeah. Okay, let's start. I'm going to present a case, a 59 years old man with underlying hypertension, BPH, and kidney problem. Presented with a 1 month history of reduced effort tolerance, mild dizziness, loss of weight. He did not complain of any bone pain. No hepatosplenomegaly, no lymphadenopathy. Unfortunately, the skeletal survey was not done during that time. The investigation shows full blood count shows pancytopenia with HB of 3.7, white cell of 3.3, and platelet of 89. Renal function shows elevated creatinine, 255, with reverse albumin globulin ratio, globulin 88, albumin 25. Corrected calcium was borderline 2.5. Later we will see the PBF. The serum protein electrophoresis shows presence of IgG kappa, paraproteinemia of 72.7 gram. Okay, let's see the peripheral blood film. Okay, if you can see the film, there is a background coloring with significant rouleau formation. Can you see the rouleau formation? Okay. These are neutrophils and 2 lymphocytes. Okay. So here you can see a cell with some inclusion bodies, aura-like in the cells, in the peripheral blood film. Other than that, the number of plasma cell in the peripheral blood film is less than 5%. No obvious abnormal lymphoid cell seen. Okay. So the bone marrow was done because they are suspecting multiple myeloma.
There is no leukohydroplastic change, huh?
Yeah.
Okay.
So this is the bone fragment. This patient is 59 years old. So it is hypercellular with partially hemodiluted cell trails, but the cell trails mainly consist of these abnormal cells, which most of them are eccentric with eccentric nuclei, and we can see intra cellular inclusion, outrod-like, okay, and also the extracellular rods. So these cells, the plasma cells, has outrod-like inclusion in the cytoplasm. So most of the cells are small to medium size with eccentric nuclei, with visible intra and extracellular outrod-like bodies. Okay, and also there are some cells having multiple, like faggot cells, like this.
There are also many lymphocytes, is it?
Yeah.
Okay.
Mm-hmm. So we proceed with the bone marrow IPT. Initially, I thought it is multiple myeloma, so I proceed with multiple myeloma tube. So here you can see in the CD45 versus site scatter, the population is CD45 intermediate with moderate site scatter at the blast window. It expresses CD19, but weaker compared to the normal B. CD38 and 138 are also positive. And the abnormal population showing kappa light chain restriction in the kappa lambda box here. So it's a clonal B cell. The problem with this is it expresses CD19. Usually for multiple myeloma, the CD19 will be negative. But in this case, it is CD19 dim, but it lacks CD45, meaning it is not matured component. But they are having, what I mean is if you suspect B cell lymphoma, the CD45 should be in the lymphocyte window. But here it is CD45 intermediate. And the CD56 and beta-2 microglobulin are also positive. So, correlating with the, the morphology, a lot of plasma cells and also inclusion bodies. Initially, I thought this is multiple myeloma. So let's look the trypan biopsy. So there are adequate marrow spaces, which is hypercellular. Okay. And if you notice that the whole marrow spaces are infiltrated by these abnormal cells. The normal hematopoietic cells are reduced, replaced with these small, medium to large cells, and they are showing eccentric nuclei. So you can see some erythroid colonies here, but these abnormal cells, plasmacytic morphology, involving all the marrow spaces. The T cell, CD3, basically the CD3 population are scattered. Okay. And the CD79A cells, positive cells, are diffusely infiltrate in the marrow. So we know that we are dealing with B cells or plasma cells component here. But CD20, the CD20, they are very strong. The abnormal cells shows strong CD20 expression, which is uncommon to have in plasma cells to have strong CD20 expression. And the abnormal population, they are CD5 negative. Sorry, this is CD10. Okay, they are CD5 negative. Okay, this is CD5. This CD5 follow the T cell pattern, and this is CD10. So CD10 are also negative. Okay.
Is the CD10 marking all the blood vessels, right?
The CD10?
Yeah, it looks like the positive
it seems like they have
now.
background staining.
Oh.
Background staining, and then they highlight the residual. Some of them highlight the residual grand series. But the cells and in the background are negative.
Yeah, okay. Agreed.
Okay. And for CD138, the abnormal B cells that we saw, which express CD79A, CD20, they are also CD138 positive, similar as the IPT result. So CD138 is quite specific for plasma cells. And they are also positive for PAX5. So this is PAX5 nuclear staining. You can see the abnormal cells are positive for PAX5. So plasma cells are usually PAX5 negative. So because of this, it is a B cells pathology with plasmacytic differentiation, and these abnormal cells are this is kappa. Okay, this is kappa, and this is lambda. So they are kappa restricted. So we have clonal B cell pathology. So the differential it would be lymphoplasmacytic lymphoma or plasmablastic myeloma. So the Ki67 you can see the Ki67 they are increased more than 30%. Usually for lymphoplasmacytic lymphoma, the Ki67 will be low, but plasmablastic myeloma or lymphoma, the Ki67 is almost 100%. So we know we are dealing with the B cell pathology because of first is strong CD20 positivity and positive PAX5. So the diagnosis that we made is diffuse large B-cell lymphoma with plasmacytic differentiation. So it is not LPL because of the high Ki67. It's not plasmablastic lymphoma because of the Ki67 is not approaching 100%. So usually, if this is plasma cell pathology, the PAX5 will be negative because the development of the plasma cell it require negative suppression of the PAX5 expression. So, is there any question?
Since there's a prominent lulo formation, also increased globulin, is there any result from serum electrophoresis? Is there a paraprotein in circulation?
Yes. Serum protein electrophoresis shows 72 gram IgG kappa paraproteinemia.
Okay. So do you think this is actually lymphoplasmacytic lymphoma?
The Ki67 should be lower in lymphoplasmacytic lymphoma.
Okay.
But the LBCL involving marrow is quite rare. Usually, this patient should have extramedullary involvement like lymph node, but in this case, there is no lymphadenopathy, hepatosplenomegaly.
Yeah. Somebody mentioned whether, whether the genetic mutation MYD88 was done or not?
It was not done.
Oh.
From I checked this patient because this patient from Sandakan. The last follow up was in August or October. After that, no subsequent follow up. I'm not sure what happened to the patient after that. Because here, if you want to send the molecular for MYD88, you need to send to private lab.
Yeah, understand. Yeah. Okay. So the only thing is the cells seems to be all very small lah. So
yeah,
wonder
from
if
the
it fit
morphology and
into
the experience, it seems like small.
Yeah. So it doesn't look like it's fit into the large cell lymphoma. So more like I mean, the morphology, if you would send it to me, give it to me, I would probably say it's LPL lah. Yeah.
But the serum protein electrophoresis is IgG. It's not IgM.
So it looks like, that's right. The only thing unusual is that, of course, the IgG kappa paraprotein. Yeah. Normally, in LPL, it would be IgM. Yeah. Yeah.
But after this, we will show you another case that has a similar kind of story.
So then in that case, we will let's see whether any comment from other people. Yeah. If not, then we proceed to the second case, right? Which also is a plasmacytic problem, and let's see how it goes.
Testing. Prof, can you hear me?
Can.
Okay, Assalamualaikum and good evening, everyone. So I'm Hatta. I'm going to present the second case for today. So this case was just recently discussed, actually just yesterday, with our clinical hematologist for diagnostic dilemma, actually. So this is the case, 55-year-old female with underlying IHA since 2009, and she had history of rituximab times 2 in July 2022, but then noted HB trend drop in April this year, and hence they started on prednisolone. She also had trial of azathioprine in July this year, but withheld because of further drop in HB trend, and was increased back on her prednisolone. So recently she admitted to the hospital after she presented with history of fever, lethargy, reduced her intake, and also low stool. And in the ward, she had persistent fever spike. And at the time, the FBC presentation was low, HB was 6, total white is only 0.9 with normal platelet 218. And she was covered with antibiotic for neutropenic sepsis. Otherwise, physical examination, lung is clear, abdomen was soft, non-tender, no hepatosplenomegaly, and no palpable lymph nodes. PBR was done at that time. At the time, the HB was severe anemia, vertical of 2.9. There's microcytosis over microcytes and erythrocytes with mild perichromasia. White cell, otherwise severe leukopenia and neutropenia, no left shift or blast, and platelet was adequate. So this is just a bicytopenia with no electroconvulsive picture or any blast or any abnormal lymphoids. Okay, so I start with the bone marrow. Then actually patient did a bone marrow in one of our district hospitals. So this is the PBF during the bone marrow day. At this time, patient's HB was 6.8 with MCV of 90, MCH 26.9. Total white was 2.86 with ANC 1.3 and plate was normal at 300. Other examination, renal profile was normal. LFT shows reverse in albumin globulin ratio. So actually for this time, the peripheral blood show this mature neutrophils, and then of course there are some less shifted cells, there are myelinocytes. And then there's also occasional nucleated RBC. So there's a leukotroblastic picture. So we have here one myelocytes. Yeah, two of them. And then what we have here will be the nucleated RBC. And actually there are very occasional circulating plasma cells. So if I can find one, oh yeah, it's like this. Okay, this kind of are very occasional. So for the bone marrow, the PBS shows leukotroblastic picture with very occasional of this plasmacytoid or plasma cells. There's no blast or any other abnormal lymphoid cells. Okay, this is the bone marrow extract stain at the district hospital. So it's not really a good marrow smear, but we can see the marrow is actually hypercellular, but the cell flow is not that good. Okay, but when we look at higher power, we don't really see the plasma cells, but there's a lot of these granulocytes and erythroid precursors. Bila? Sama mana ni? Tinggi sangat. Tak cantik pula high power dia. Okay, lambat fokus. Okay. So I put it under a bit lower power so everyone can see. Yeah, there basically there's a lot of granulocytes and nucleated RBC, few of these plasma cells. So actually, when they reported this one, this marrow, they only mentioned as erythroid hyperplasia and peripheral reticulocytosis likely secondary to underlying IHA. But otherwise, there's no increase in plasma cell or any blast or even abnormal lymphoids. So
Do
that's
you think there are aggregates of erythroid cell?
yeah, actually, this one a lot of this call it a bit clotted sample as well because all these erythroid they are also already aggregate together, and they are also the platelets. So it's not really a good smear.
Do you think actually the so-called aggregates of erythroid cell, is it within a macrophage? I cannot see very clearly because it's a bit blurred.
Oh no, actually there's no macrophage around the cells.
Oh,
Yeah.
not you think it's not erythrophagocytosis?
No.
Oh, okay.
I like this one. I don't know. They kind of stick together.
Yeah, I don't know why they stick together.
But that's the interesting one. Because of how we do what we do here, basically, if there's a specialist, so they're going to report the bone marrow aspirate. But for the IPT and refine, they're going to send to us in HQE. So we receive sample for the IPT. So this is a smear, EDTA smear from the IPT. There are actually a lot of plasma cells, totally different finding from the bone marrow aspirate. For example, this one, a lot of plasma cells for the EDTA smear.
Yeah, so many, yeah.
Yes, totally different findings. So we're going to get back to that, why there are difference. So because of there's a lot of plasma cell, just like the first case, I thought it was a multiple myeloma case. So what we did first was the IPT for plasma cells for multiple myeloma. Macam mana full screen ni? Control L. Control X. Control L. Control L. Okay. So this is the PCST tube for the plasma cells. So basically this is all the cells that are level we can get. So I'm using for analysis. So I'm going to just show you the population of interest and also the residual normal plasma cells. So this population of interest or the abnormal plasma cell, they are actually CD45 positive, CD19 positive, CD38 positive. I'm not going to comment regarding the CD138 because we have some issue with our CD138 recently in this current batch. A few cases of plasma cell, they have negative CD138. Whereas when we check back in Refine, all these plasma cells are CD138 positive. So I'm not going to comment regarding the CD138. And this plasma cell actually have the kappa light chain restriction compared to the normal plasma cells. And they are slightly CD56 dim positive. So now we have an abnormal plasma cell that express kappa light chain restriction. So not just going to see the plasma cell, we actually try to see the whole population. If we check the B population, it seems a bit weird because under CD45, the B cell have a really high, moderate to high subscatter compared to, for example, our T lymphocyte. Our normal lymphocytes usually have a low subscatter. And these B cells, what we can see here is actually the kappa lambda expression is not, they're not expressing this both kappa and lambda. They basically form a one big population here, but it's really hard to interpret from here whether it's kappa or lambda. So because of presence of this abnormal B cell as well, so we proceed with our lymphoma panel screening too. So this is just a normal plasma cell and the T lymphocytes. So for this tube, for the multiple myeloma tube, we get about B cells, and the abnormal plasma cell, there's only like 9% that still alive at the time, survival. So for our multiple myeloma tube, we have abnormal plasma cell that are expressing CD45 positive, low scatter CD38 positive, CD19 positive, BTM, CD56 positive gene with kappa light chain, and there's possibility of presence of abnormal B lymphocytes. So going on with our lymphoma panel screening. So the blue one is actually the abnormal B lymphocyte, whereas the purple one will be the abnormal plasma cell that we got earlier. So here you can actually see better that actually the B cell, different population compared to our plasma cell, and this B cell actually have this kappa light chain restriction as well. So now we know this is really an abnormal B lymphocyte that expressed on the kappa light chain. So I'll proceed further with B lymphoprotective tube. So I just show the abnormal B lymphocytes. So in this tube, you can see these abnormal B cells, B lymphocyte cells. They are CD19 and 20 positive, CD200 negative, 23 negative, 43 negative, and 79B positive, 200 negative. As for our second tube, the same population, they are normal plasma cells. They are CD103 negative, CD81, what's that normal? They are still positive. Yeah, this one still positive team, and their HDR pos. The only abnormality here I would say would be the CD11C. They are also positive for the abnormal B cells. So in conclusion, from the IPT, we got two abnormal population, the abnormal B lymphoid cells and also the abnormal plasma cell, both expressing kappa light chain restriction. This is the patient's triphan biopsy. The triphan biopsy, they are markedly hypercellular for age. Patient is 55 years old, whereas the cellularity here is almost 100% from one end to the other end. So under high power, here, this is one of the marrow space, quite hypercellular. We can actually still see in this marrow space there are mature neutrophils, but along that we have some of these lymphoid cells and plasma cells. But if we go further to other marrow space, there's a lot of these plasma cells and also lymphoid cells. Boleh tunjuk kat mouse. Oh, okay. For example, in this area, there's a lot of this lymphoid cell with only occasional mature neutrophils. And we also have plasma cell among them. A bit difficult to be seen here, but it's quite clear under the microscope. Here's better. So you can see in this area, there's a lot of these plasma cells with very occasional granulocytes. Okay. So the next one, what I'm going to show will be the CD79A. Okay. Almost all the cell pick up CD79 alpha. So CD79 alpha can
be picked up by our B cells and also our plasma cells. So under low power, almost all the cells pick up CD79. So there's a diffuse infiltration. Then we have our CD20. So yes, there's increased CD20 positive cells, but at the same time, there are some cells that didn't pick up the CD20, whereas CD79, every cell pick up the stain. For example, in this area, we have this one big aggregate right in the middle. They are CD20 positive. So I'm just going to compare with CD3 for T cells. So these are the CD3 for T cells. A bit increase, but likely reactive. So this is our pattern for CD3. Next will be my CD5. Okay, this is CD5. CD5 basically follows the pattern of CD3. So the CD20 cells is negative for CD5. How about CD23? CD20. So actually CD23 is negative. Because T cell can also pick up for CD23. Then we have our cyclin D1. So yeah, cyclin D1 is also negative. Next is CD10. CD10 again, they are negative, only very scattered positivity, probably some residual granulocytes. Next, I'm going to show you my CD138 for plasma cells. So again, CD138 increase, a lot of cells picking up this CD138. If you compare to the CD20 earlier, you can see there's like an empty space right in the middle where the CD20 form and aggregates. So we actually have two population of cells. One are CD20 positive, CD138 negative, whereas the other one will be one CD138 positive, but CD20 negative. But both pick up CD79. Next for my kappa and lambda. So this is my lambda. Very few cells taking up lambda. And next is my kappa. Very nice. So majority of the cells are expressing kappa rather than lambda. Next would be my Ki67. Okay, this this is my KIC7. KIC7 is actually low. KIC7 index is about probably 10 to 15%. Next, I'm going to show the IgG, IgM, and IgD. So this is my IHC for IgM. Versus IgG. So basically this abnormal cell there expressing IgG rather than IgM. Do have IgD, but they are basically negative for IgD. So this is my gene sustaining. So looking at the mast cells are basically easily seen. There's not much increase, but tak ada pula. Mana tadi? Okay. For example, these are my mast cells. So only slightly increase easily seen in mast cells. So in conclusion, for the the bone marrow triphangosy is hypercellular marrow involvement of a low-grade B-cell non-Hodgkin lymphoma and the displaced hematopoiesis. So the most likely differential in this case is the LPL, lymphoplasmacytic lymphoma of IgG kappa type. But given that the non-IgM LPS are uncommon, another differential will be marginal zone lymphoma with plasmacytic differentiation, and because it's difficult to differentiate both solely based on histomorphology and also immunophenotype. So we actually suggest whether if patient is financially able to send for T8 or CXCR4 mutation. So this is the CT scan of the patient, actually, newly diagnosed B-cell lymphoma. So there are no enlarged lymph nodes, but patient actually had this multi-level vertebral compression fracture. This is an old fracture actually from the history that I got. They actually attribute this compression fracture to prolonged steroid use. Oh, I didn't have another one. Oh, sorry. Put it in front actually. So for the serum protein electrophoresis shows presence of 2 IgG kappa paraprotein. One at concentration of 41.3, whereas the other is 1.7 with immunoparesis. Urine paraprotein was negative. So this is what we discussed yesterday because the clinician a bit have a dilemma calling it LPL because of the IgG. That's a bit uncommon, but then again, the morphology, the IPT with two population of clonal plasma cell and also clonal B cell basically in favor of LPL. So that is all from me. If there's any other questions.
So how do you explain the the two clonal population. Do you think you hypothesize maybe one clonal is actually come from the plasma cell, the other one is actually from the clonal lymphocytes? Is it a possibility?
For the serum protein.
The protein
I think
electrophoresis, you see two monoclonal bands, isn't it?
Yeah.
So wonder whether is it due to different clone of cells, is it?
Yeah, it's possible because one may be coming from the plasma cell, whereas another came from the abnormal B cell. Whereas for the last time when I present the case with two lymphoma, one actually expressed kappa, whereas another one expressed lambda, so different light chain restriction. But in this case,
so
it's actually both expressing kappa.
Yeah. Okay. Yeah.
And
I think
just like to mention, because when we see earlier, the X-ray actually didn't show much of plasma cells. So when we did the IPT here, we informed the pathologists at the district, at the hospitals to review back. So they actually stained the other slide that they have, and only on the other slide they managed to get the same picture as us, a lot of plasma cells. So possibly what they got is the non-representative area for the aspirate. Maybe they got the area where the patient had this erythroid hypoplasia because of prolonged anemia and IHA.
Yeah, it's got an IHA, you see. So presumably because of the sampling site. Yeah, sure. So I don't think we got problem with this case. I think it's a straightforward, not straightforward in the sense that not the IgM type or LPL, but it looks like it's the IgG type or LPL. Yeah.
Yeah, we actually had a few of these cases.
Yeah, actually, when I look at these two cases, wonder whether actually they are just variant of the same LPL, So the first case also, I was thinking maybe it could also be a LPL as well. Maybe you can actually go back to review your flow result again, whether you can actually isolate two population of cell. You may be able to see that there is another separate. Remember just now I commented actually in the bone marrow smear, it seems that there are quite a lot of lymphocytes as well. So wonder whether from your flow you can actually therefore identify the separate lymphocytes, whether there is also clonal in origin. So in that case, then the diagnosis may be in favor of LPL rather than DCLPCL with plasmacytic differentiation.
Because I think the first case was also we discussed with our hematopathology consultant, because the issue will be the CD20 positivity, very strong in that one. The PAX5 and also the very high, not too high, but high Ki67, which is against LPL. Actually, initially thinking it's LPL.
But even Ki67 is not that high, Yeah. Yeah, moderate maybe, yeah. It's still within that sort of variation of Ki67 among the LPL. Yeah. Anyway, we open up the case. Anybody seen such cases? Very uncommon. Yeah. It's nice for the Queenie team to share these two cases to us. All right. Okay. So I think it's a very educational session. Thank you very much for the Queenie team for putting up two very interesting cases. Yeah. So for those people who are celebrating Christmas, so Merry Christmas, and we all will be celebrating the New Year coming. So Happy New Year to all. All right.
Okay. Thank you, Prof, for inviting us.
Thank you. Right.